Before everybody starts, I'd like to kick off with a question. A little bit from the patient focus, or let's say people focus, because we're all patients at the end of the day at some point in our life cycle. In a population health strategy and the use of big data is going to be incredibly important to be able to change plan and take into context, I really like that whole aspect of taking into context the social environment. But at the moment, we're missing something a little bit, which I think is quite important. We already know that big data is working extremely well with social profiling and behavioral sciences. In fact, that's where it really kicked off with big tech industry. And in a way, we're detaching that from the clinical experience, the clinical data. And yet we know if we want to achieve behavior change in people about their treatment and taking ownership of their condition, whatever it is, we need to work with behavior. So I'd just like to know what any of you feel about that, and if you think that in the future you'll be taking in that data in parallel. Could someone give me some feedback?
Well, I think for the hospitals, in our model, we need data to make decisions. And we see that we don't have the data, or the data are not structured in a way that they can be used easily. So it's an important part to have those data. But on the other hand, we see that if we have to tell patients that we need lesser hospital beds, the population says, oh no, we need bigger hospitals, because when I go to the hospital, I want to have a bed, I want to have everything in my neighborhood and not a hospital 20 kilometers further. So it's a big change on both sides in the system and for the population.
So ICIC was developed before I joined Imperial, and it was developed by, I suppose, a partner organisation rather than Imperial itself, but we collaborate quite closely with it. But from what I understand, it was when the idea was developed, there was a patient group, and it was kind of co-developed and co-designed with them. I think, as Kush alluded to, there is and that group has intermittent kind of oversight with how the data is being used. Obviously, we needed to get the patients to agree that their data could be shared in the way that it was being shared, and so there was all those governance structures that needed to be put in place. There is a question around how you use that data. So one aspect of it could be, for example, because we've made it available to clinicians, could a clinician sit with the patient in front of them and kind of go, look, this dashboard shows me that you were, I don't know, going to your GP or your outpatient service this many times, and then something happened, you went to A&E, what was going on there, and kind of use it to open up those kinds of conversations. And I think that's an iteration that hopefully we'll be moving towards. I don't know, as a clinician who uses it, if that's something that resonates.
Yeah, following on from that, it's really interesting you asked that, because it's probably not directly answering your question, but not only is it translating the data to the people we serve, but then also our colleagues, fellow clinicians. How do you, I can't think of a GP who gets off on listening about demographics around the population, but then if you show them, for example, the timeline, the dashboard of their patient, then that adds to their sort of clinical discussion with their patient, and then it starts to hopefully open up those conversations where the data can actually facilitate that consultation rather than it be something that's depersonalized.
Yeah. And David, are you getting the translation? Yes. So from Madrid perspective, it seems you've got a huge population with chronic disease issues. And I wonder what kind of role is the patient taking on in responsibility for their own self-care with chronic disease. Can you achieve any behavior change with patients, do you think, looking ahead, now that you've structured the healthcare system to attend to them in let's say, a closer way?
Sí, en la Comunidad de Madrid.
Yes, with this change in our region towards more dynamic stratification, which is now more focused on low and medium intervention levels, we are looking for more and more active patients. This is all focused on self-care by the patient, not only on the level of integrated care processes, but also on the level of other processes. For example, structured training. The region of Madrid has been developing structured training to clinicians and also to patients who are retrained to learn what they have to do.
Responsibility onto citizens now for the self-care is an essential part of our partnership in health between the healthcare system and patients. Do you have any questions amongst yourself first and then take it out? Or do you have questions here that you'd like to bring into the panel? This Tim.
I have two questions. The first question is addressed to the Jose or David on the stratification. Have you done any correlation studies or analysis whether those stratification models that you use lead to better outcomes that are people-centered, that patient value-centered? I'm just thinking along the lines of, are those stratification models you use demand-based stratification models, or are they supply-based stratification models? Because linked to what Chairman is talking about, there are behavioral needs, there are needs and wants of the patient. They are not necessarily medical. So how would we use stratification to segment the population so that we can target interventions to tackle non-medical issues? The second question is targeted at the WISIC group. Is it GPs alone that look at your dashboards? And are they competent, or are they comfortable to look at all the interventions needed that the data is throwing up to them? Because some of the data may come back as interventions that are beyond the GP realm. For example, crisis or, for example, acute care type interventions may appear in your data. So who looks at the dashboards, and are the people who look at the dashboards the same group, or there are multiple people looking at the dashboards?
You want to? Yes.
So in answer to your question, all clinicians in Northwest London can look at the dashboard, and you're right that I think some of what you alluded to is it a little bit of information overload, and it can feel that way for a lot of clinicians. In reference to the question around, well, obviously, if someone goes into a crisis, is that the fault of the GP, or if someone has a mental health crisis, is that the fault of a community provider, whatever it is? But actually, that's the conversation we do actually want to emerge from looking at the dashboard, because we are developing an integrated care system. So it's the collective effort of every partner in that integrated care system that should be saying, well, actually, are we as a group of professionals not providing the holistic care that we want for this individual? So it shouldn't be that it's targeted towards one or the other, but yes, in reference to your earlier question, it is a journey, and gradually more and more professionals are looking at their data. And I think it follows with, so in the last year and a half, we've had much more uptake of data that's going from GP surgeries into the dashboard, and with that there was more interest, so you've got more GPs looking at it, but I've had colleagues who've spoken to me informally that other providers, for example the Acute Care Trust or a Community Mental Health Trust, bar a few people who are involved in discussions around integrated care, have not looked at it, certainly not frontline clinicians, so a consultant psychiatrist, an acute care physician, a care of the elderly consultant. But as we try and work together, the idea is that it opens up more interest, and more people look at it as a utility.
Any other questions? No? Oh, sorry. Yes.
Regarding your question, in the region of Madrid, we do have correlation data between the levels of risk and the levels of intervention. They are currently being validated. They are real data. And regarding the question about whether we've achieved so far, yes, we have a primary care network. We are extrapolating those data to the network to check whether the users are carrying out the activities. As I said, we have been using these intervention levels since April 2017, so there is a relative progression. We started with the patients at a higher risk. We've reached 66% of level of intervention assignment, and now we're validating the data on the indicators level, which are the ones that are now more widespread in Madrid. Then there are also phone calls or follow-ups by the primary care centers, activities carried out with nurses, hospital admissions, and so on.
I've got a question, Dick. I find it fascinating that you've working with children and youth, because evidently, let's hope it should be easier, you know, to change behavior and so on, and the social context. So as far as education is concerned around health and social well-being, is that very powerful also in this whole strategy by the government in Queensland?
Yes. Is the microphone working?
Could we check on his sounds?
Is it working? Yeah, thank you. As I understand your comments is around the importance of education. Are you thinking about health literacy for children and young people and families? Yes, critically important, but I would also reflect that health and well-being isn't the purview of health alone. So when we think about schools, when we think about communities, when we think about other parts of our social system, we have a job of work to do to lift and raise the health literacy of our communities. Parents, school teachers, early school teachers, the list goes on. So I'm hopeful that we are shaping our narrative to be able to do that, but I think that the biggest challenge that we have is that most of our institutions and in our ways of working are populated by people of my vintage, and that is problematic.
Yeah.
And that's where, in my view, we need to really focus our efforts. We have to think about shifting policy, we have to think about integrating thinking and bringing departments together who make decisions about policy. Because as we know, there is a policy lag phenomena. So the community, society they're rapid adapters, whereas our policy sort of trundles through the portals of government and will emerge maybe 12 months hence. So we've got a job of work to do to bring our generation on board with how things need to be different in the future and shape policy in that sense.
Do you have the digital capacity to bring together the information from different institutions? I mean, it's very widespread. So do you have a platform which is enabling the communication of data and input from
Yes, we have, but it isn't sophisticated at all. And I think that that's one of the challenges when one embarks on planning at a systems level. There's this notion that perhaps you need to shift legislation. There's this notion that perhaps you need to have some kind of, a mega capacity. In fact, we are reporting this information as government agencies and as health systems. We have all the processing power at our disposal. Currently, it's about focusing that. And I think our colleagues from the UK might agree with that assertion. Yeah, it is really about focusing it and about giving us a reason to pull it together in a meaningful way. Yeah. We have the capability and we have the capacity. It's about thinking differently.
Yeah, and I resonate. I think it's interesting that it's not the technological limitation we're talking about. It's
human limitation.
It is, isn't it? Yeah.
It's always the human limitation. Any other questions here from the audience before we close? Yes, sorry, there's a lady here.
Thank you very much. Anya Carroll from Dublin, Ifig, Ireland. I think it's very easy to get seduced by the possibilities of big data. And I really like the idea that Frank said about using it to paint a picture. But painting a picture and making a compelling case for change is all well and good, but how do you actually effect that change? Do the panel have a view on that?
What I hoped to emphasize in my half of the talk was around the idea of data as a tool. And as with any tool, it can be used either productively, or you can ask ineffective questions of it and you'll get ineffective answers back. And I think that you're right in that big data has become kind of this buzzword, or the stratosphere of buzzwords, and people forget that actually it's just a tool, and the important thing happens afterwards around kind of, so when you've got your data and you've done your analytics, how do you actually do the change management? How do you actually redesign care? How do you bring your staff and your patients along with you? And that is a much wider and probably a bigger challenge than actually having the capabilities.
But it must help with the scope.
To scope out where to start, and also it's not a linear thing, is it? It's a cyclical thing. So you ask the question of your data, you implement change, and then you come back to it. That's something that it allows you to do. But provided that you have, for example, the leadership, the strategy, the idea of how you're actually going to use it.
Anything else before? I think we're about to close now. But any other last comments? No. Okay, well, thank you very much. I find it fascinating personally, and I hope to discuss some of these things with you after the session. Thank you, everybody.